to today's Curious Case Manager. I'm Vicki Gilman and I am the Curious Case Manager. And today I have with me Graeme Flaherty-Jones. And Graeme is an Associate Clinical Director and Locality Lead for Psychology in the NHS. He's also a Director of Clarity and works as a clinical psychologist within that team. Graeme, welcome to the Curious Case Manager.
Thank you for having me along.
And I think today we plan to have a conversation around working in teams, working with clients, and how to achieve psychological safety within the team. And in the style in which we sort of had a little chat beforehand to plan this, I haven't got the sort of prompts that I normally have. I decided to invest in the idea of psychological safety in our discussion and just be guided by where we go.
Yeah, I think that's very in keeping with the tone of where we're going to have conversations today, hopefully. So
it felt a bit hypocritical to talk about psychological safety and some of the things I know we'll come on to about preparedness and have it all too scripted. So can I just ask you to start by just telling us a little snapshot of your career and how you've ended up in those roles that I've just explained?
So as you kindly introduced there, so I work as a consultant clinical psychologist, both in a neuro rehab private sector and clinically in the NHS within older people's mental health services and some of the younger onset dementia neurological condition services. And I guess my background really and interest in sort of these issues of trust, team working, stem from some very fortunate opportunities to be guided with mentors around leadership. So early doors, kind of had some involvement in developing a leadership development framework for the profession when I was a third year doctorate student. Actually worked with some really wonderful mentors, Tim Kate, Sarah Dexter-Smith, Sarah Hopper, a few individuals who've had quite senior leadership positions for psychology at a trust and national level as well. And I guess that's really always been there as a curiosity for me in terms of how do we get teams to work as effectively as they can, because it just seems to be that when they do, everybody benefits, namely the client and the family and the staff that are working in it. And I think I realised early on that to kind of get as far as I really wanted to with clients and with families, that we had to acknowledge the team and the working relationships in those teams. And so it's always been an interest of mine. I'm probably also lean a bit more towards systemic preferences as a theoretical model for clinical psychology. So the two, family therapy, systemic working, organisational interest, leadership, brought me to kind of this sort of position of real interest in the concepts you've mentioned around psychological safety, trust, teams, those kind of things. So.
And I think I can relate to that, having worked in some really good teams myself, some of which with yourself and colleagues. And I think probably everyone will relate to the idea and the feeling that when you are within a safe team, a really good team where it is working really well and you get that great outcome for clients and families, it has a feel about it. You know when you're in that place, don't you?
Absolutely. And it's funny, isn't it? Like when you think about psychological safety or trust, it's quite intangible, isn't it, to say, well, what is psychological safety? What is trust in a team? But I think you always know if you've not got it, and you know if you've got it. You know, if you've not got trust in a team or in a role, I think you just feel less at ease and less able to be your true self and bring your full potential to that role. But it's quite hard to put a finger on what it is exactly that sort of tips it into not feeling psychologically safe. There's a lot of that unspoken sort of dynamic, but where it's there, like you said, I think you just feel it, and it kind of allows you to be your whole self, your genuine self in that forum. And I think that's what really brings out creativity and so many good things for the client.
So if it's quite hard to define that psychological safety off the bat, can we have a stab at thinking about the features of a team that would have that about it? Some of the things you might notice, some of the things you might be thinking to encourage? to achieve
Yeah.
psychological safety?
Yeah, I think the easiest way of probably trying to get close to a definition or describing what it looks like, I guess, for me, is that if we feel comfortable to be vulnerable, and I don't think any of us really like being vulnerable, but if you have a sense that you can be vulnerable without fear of sort of being persecuted or criticized or humiliated, and they're big terms, and rarely does that tend to come up overtly, but we all as humans sort of have those innate feelings in teams. If we're a bit worried about looking ignorant, then we don't ask the question that might be the thing that moves the team on. You know, if we fear looking incompetent, we might have made a mistake that actually has helped the client get to some really good learning about what we should and shouldn't do. But if we don't feel psychologically safe, often we won't name that we've done something wrong because we fear looking incompetent. So we don't share that learning, which could actually really improve the outcomes for the client. So on the flip side, you know, coming to what you've asked there, teams that have good psychological safety, I think you see people being able to name the fact that they don't know. Kind of saying, I just don't know what to do here. And that often breeds a really healthy conversation about, well, what's right for this situation, for that individual, for that family. Very collaborative. And I think equally people admit mistakes. You know, people are able to be fallible and say, do you know, I don't know if I got this right. But that often then allows the rest of the team to then say, yeah, no, I don't know if I got that right either. And perhaps we then get to some shared understanding that is in the best interest of the individual or the situation. So I think they're definitely some of the key features of psychological safety.
I think two things that sort of came across my mind as you were talking about there. One was that slightly hackneyed phrase about the only daft question is the one you don't ask.
Yeah.
I think it's very true, but it can be very difficult if you're sitting there concerned about what people may think about the question you would like to ask or the thing you are confused about. That's quite a difficult thing to overcome, I think. I
totally agree. And I think, you know, you and I will have all been in positions where we sit there and we're thinking, surely somebody must be thinking the same thing as me or must have this question. And then we kind of go through that internal metacognitive thing of like, well, maybe it's already been asked, or maybe there's a reason no one's asking it. And that's our internal nature as human beings, isn't it? To fear looking silly or fear looking, as I say, ignorant. But I think you're right. It's that thing of actually sometimes it only takes one person to name that or to have the confidence or the internal security to sort of break that, or, you know, the team's permission to sort of name it. And then if you can ask the question, what normally happens is lots of people then go, yes, I was thinking exactly the same thing. And, oh yeah, I was going to ask that too. And that's where the healthy sort of the good feels come, and you start to kind of connect as a team. And I do think, you know, that is where leadership plays a really important part in setting that culture, whether that's collective leadership or sort of a more directional leadership. If that culture's not there, that naming of the thing that's in the air but not said doesn't happen.
So I think the second thing that went through my mind then was about I don't know, maybe it's the same in other industries, but certainly in our sector, working in healthcare, some kind of almost inbuilt thought perhaps that one has to not make mistakes, because, you know, people and people's health and well-being is what we're dealing with, and it's really important to get it right. And it's really important when in front of a patient, a client, that they feel that you know, and that maybe, I mean, that would be impossible, wouldn't it? Nobody gets it right all of the time. We're all human, we're all fallible. But I don't know what you think about that sort of idea that perhaps there's an inbuilt feeling for us as health and social care professionals that we should know.
I think it's a really big elephant in the room. I think everybody's thinking it, or certainly we should be thinking it, because it's true. You know, if we make mistakes, the consequences to people's safety, health, well-being can be, you know, on a continuum, very catastrophic and have big implications. When you think about that too much, it kind of fills you with dread, which is inherently why it's very important to name these things and to actually have psychological safety, because it can, as you say rightly, it can kind of be paralyzing to just sit with that. And I think if you fear or sit within a cultural narrative of blame or blame, and if you feel that you're going to be kind of persecuted or criticized for having made a mistake, and if you've got evidence of that from maybe a colleague or a previous experience where you worked in a team where you were humiliated or told that you've made a mistake and you weren't given opportunities to learn from that, it can be really difficult to shake that. And it only takes a couple of people, I think, in a team to perhaps feel slightly like that. And unless there's a really quick naming of it or some good leadership to sort of dispel that culture, it takes hold and people become very defensive and start to self-preserve almost, because we're all human. None of us want to feel vulnerable. And so quickly what happens in the team, I think, is you get a lot of self-preservation rather than doing for the collective and looking after each other. But I totally agree. I think, in some ways we almost need to name the fact that if we make mistakes, it can have big consequences, but that we are all human and we are also still allowed to make mistakes. In some respects, it almost escalates the importance of naming the mistake quicker, knowing that it's okay to name it quickly so that we can learn from it, but that it will happen because we all make mistakes. But having those conversations early doors in teams and naming the elephant, it usually only takes one or two people, particularly those that are in a leadership position, formally or informally, to do so, that people then go, oh, and then they can kind of start to talk on those levels, really.
Because there is something, for me, I think, in what you're saying there about the idea that if, as health and social care professionals, I suspect we're all trying to do our best all of the time. And so if we spot a problem, we're going to try and fix it. So if there's a problem we haven't spotted, or a piece of information we didn't realise we needed, if that can be pointed out to us, there's the gold. There's where you're really going to make improvements. That's where the team is going to jump forward, or you are, as an individual, are going to jump forward, because the things that were unknown to you are going to become known, and then you can deal with them. So if you can achieve that safety that you're talking about, that psychological safety, enough to be vulnerable and to then hear it from other people, there's the potential to really escalate the rate at which things get better, either for the team, for the individual, for the client, for everyone, really.
I think you're absolutely right. And, I think I mentioned to you a while ago, there was a study done a few years ago by Google looking at what is it about our highest performing teams that makes them really, good teams. And, Google are doing all right. So they've probably got some pretty high performing teams. And they found that perhaps one of the biggest factors in their most highly performing teams was psychological safety, that they felt able to be vulnerable with each other and would support each other and name things quickly. And I think, I know we talked briefly before the interview about some of the research in the area. Amy Edmondson's work's really, really helpful to look at. She's got some excellent talks online. The work of Simon Sinek, they both point to the fact that some of the most highly performing organisations, they actually publish a lot more of their errors. So, Amy Edmondson makes some references to pharmaceutical companies and within healthcare, that if a team is publishing their errors, you might initially think, well, gosh, they must be doing very well. But actually, you could look at it from a cultural level at the inverse perspective to say, if they're publishing their errors, they're probably learning from them because they know about them. I think for me, I've had a real amazing opportunities to sit across different teams, different organisations in different positions, and one of the things I've learned is that where people don't feel safe to name the things that are going wrong, when it's hidden and implicit, it can become toxic and it can become really harmful to the well-being of the team, the skills, the ability to do what we're setting out to do. Where teams can name it quickly, like you've said there, and just address it and start to talk about it, often it allows a collective response to it, and we get past it and learn from it and improve our practice. And I think that's the goal. The goal is to try and make it feel psychologically safe, to address the things that crop up, name the errors, ask the questions, to drive forward the quality and the learning in the team.
So what would you say, what would your advice be to, let's say, somebody who's entering into a new team, not knowing perhaps whether there's a level of safety or not, but what might you look for, and what might you try? What experiments might you do to test that out, and to perhaps get a bit brave and try and achieve that openness and honesty?
Yeah, I think it's tricky because every situation, to state the obvious, would need to be handled slightly differently. But I think there are some key principles that you can try to sort of bring as a team member or as a leader to a system to try and get psychological safety or work towards it. And I think equally you can do the same for trust, but because the two obviously overlap quite heavily. I mean, from a psychological safety perspective, I personally use this all the time, partly because it's inherent in my character, I think, but I model fallibility because I make loads of mistakes. I mean, you know that, you've known me long enough, I make a lot of mistakes, but I'm okay with that as long as, I don't like to make mistakes, but I quickly model fallibility with people and say, look, I'll make mistakes and so will you. Let's just talk about it. Now, if you're new to a team, that can be arguably one of the worst things to have to talk about, particularly when you're trying to prove yourself. You're in a new role, you're in a new team, you want to show you're competent, you want to show your ability. So it's really counterintuitive to then speak openly about a mistake or a question. But I think gently, perhaps with somebody in the team that you feel a bit more comfortable with. So perhaps if you've worked with one individual in that team before, or there's somebody you just feel you click with, and it doesn't have to always be in an MDT or a public forum where we all feel a bit more uncomfortable sometimes. In those more secure relationships, trying to sort of check out, is it okay to talk about this? And sometimes naming the elephant, like we said before, having that conversation. Often you'll find if it's a tuned in team, they'll start to say, yeah, I feel a bit like that as well. And we've all done that. As soon as those conversations start, it kind of undresses it and lets you get the psychological safety conversations out. It's important we can talk openly. It's important we can share things. So I think there's definitely something about modelling fallibility or checking it out. I think definitely, one of the easiest things that we can all do is just invite other people's opinions. I do not have all the answers ever, and seldom have the best answers. So, asking the team and asking people, what's your thoughts on it? And, you'll see yourself, you'll have been in the same situation, Vicky. You go into a team, and if it's the first meeting or if it's the first opportunity to have a public sort of meeting together, there's all of that kind of wanting to prove your worth, show that you can do the job. But often it gets in the way of that collective shared leadership, shared working. But when one person says, oh, Vicky, what do you think about that? Do you think that's a good idea? It invites the other person in, and it's saying to the rest of the team, I'm fallible, I don't always have all the right answers. What do you think? And I think even if it takes courage to do that, but doing that can sometimes invite that shared coming together. And that's where the psychological safety sometimes starts to come together. So there's definitely something about fallibility. There's definitely something there about inviting other people's opinions. I think the other thing, which is a tricky one to do, is if somebody does have the courage to name something when it goes wrong, it's to kind of embrace that messenger and to really engage with them and say, it's really difficult to hear that thing's not gone well, or that this hasn't felt comfortable or whatever. But I'm really glad you came and talked to me about it. And doing that behind closed doors or in a meeting is again another really clear way of showing that it's safe to be vulnerable. It's safe to be in a not knowing position here. So if you're coming into a team, into a new role, asking questions, modelling fallibility, these are all really important things that we can just do, as well as inviting other people's opinions.
And I think one thing I think it's important to say is that you were saying there that you made lots of mistakes, and we've worked together for some time now. And I was just running through in my mind. I can't think of a single one to name. It's not something I think of, but I think this is an important point. It's not something I think of in association with you. What I do think is that you're someone I can ring up and just talk something through if I need to get my head around it. That you're someone that within a team, even if the rest of the team was totally new people I'd never met before, I'd know I've got that trust in you. So if you have made mistakes and done that in the past, which, I can sort of recall perhaps, but I don't think of you as someone that makes mistakes. I think of you as someone who makes me feel safe, who I can share things with. We can be fallible together. So I guess that's an example of exactly what you're saying, isn't it?
It is, and I think hopefully if we've handled those mistakes, for the record, they're not catastrophic, touch wood, but like every human, we make a lot of mistakes. In a weird way, it probably is telling that they don't ring true or they don't stand out for you above other things because we've probably talked about them. So you'll know yourself, if you've got a member of a team that you're working in and you happen to hear about something that's gone terribly wrong, or has, God forbid, something's happened to a patient or a family member, a client that you're working with, if you hear about that through the back door, it's awful. And you know as well as I do, it's that sickly feeling. You think, oh gosh, how did I not know about that? Or why am I not aware of that? Or why have they not come to talk to me about it? That's the ones for me that stand out in my memory. And I can reel a few of them off now because I, in that moment, start to think, why didn't I know about it? How did that individual not feel able to come and tell us that happened? I want to support them with it. How have they not talked about that? It's probably because at some level they've not felt psychologically safe to do it. There might be other reasons, but if someone comes to you and says, Vicki, I'm really sorry, I think I've done something wrong, I think I should have done this, but that, the fact that you're brought into it, the fact that you are then part of the collective problem solving in relation to it, probably means that you feel it's been resolved and you put it to bed. It doesn't stand out in your memory. And I'm hoping that's why you don't remember some of my mistakes, because we've worked through them, we've talked about it, like we all should do. But I think that's a really good point. It's the ones that we don't know about, and it's the ones that we find out about later that do stand out because we've not had the opportunity to engage in them, rectify them, support the individual who might have been harmed and the individual that might have made a mistake through it. They're the ones that I think do stand out.
Which is an interesting reflection. Not that one wants to get too tied up in it, but they're perhaps then worthy of reflection to think about what the circumstances were that perhaps didn't engender that psychological safety, I guess, because that would, particularly if that was still an existing working relationship team that you're working within, that would help to understand what the factors there might be and how to...
Absolutely.
So thinking about that psychological safety within teams, there's obviously a relationship having a psychological safety within a team, and that then moving on to that amazing team working that you're talking about and the outcomes for patients and clients and families. I'm wondering about the sort of achieving trust and psychological safety within the working relationship with the patient or client, and how that works.
Yeah, and I think inherently, and this has always been my experience, whenever I've been in a team where I feel really psychologically safe and I feel very comfortable with those around me, it's like any secure relationship from an attachment perspective. When we feel secure, we feel able to go off and explore and experiment and sort of see different angles to things. When we feel very under pressure, just like standing on a big stage in front of people that you've never met before, being kind of scrutinized, it brings us into a atypical way of being. It makes us not be human. It stops us kind of being in the moment. And I think there is definitely an overlap. There are many other factors that affect whether you can be secure with someone in the room, but just to draw that point that you've made reference to, I think when we have a good, trusting, psychologically safe team where people are looking after each other, there's a bit of benevolence there and looking after each other's interests. There's a sense of, people doing as they say they're going to do. There's some integrity. They don't feel being criticised. They can be vulnerable. You carry that with you, like of course you do, into the therapy room or into the clinical space that you're working, and it kind of sits like an anchor, I guess. It kind of anchors you to the floor and makes you feel quite secure. And I think when you're in that place, I think we've had a conversation about this before, haven't we? That when you are not worried about putting on a show. You can be your whole genuine self in the room. When you can be your whole genuine self in the room, you can listen. You're not thinking what you're going to say next or what you're going to do next. You're just in the room. And when you can listen, you can get to people's needs, and you can think about what you can do to then respond to those needs and validate that individual. But that seldom happens if you're very, very aware of what you're doing, and if you're very worried you're going to do something wrong, because you're just not being human, you're not being in the room. So I think the team does enable a security that allows you to be present, be human in the room. I mean, we can probably come on and talk a little bit about that. You know, there are some slightly different but still linked factors that enable somebody to be in the room and forming a good, secure, therapeutic alliance to then achieve good outcomes for the client.
And I think one of the things when we had a quick chat about what we might talk about that you mentioned was in those kind of scenarios, perhaps an MDT with the client or whatever, or just when you're going in to find out information, if you go in too prepared, that perhaps you already know what you are going to say, perhaps you're already expecting certain things you're going to find, and then you're not present and you're not really listening, you're not really hearing. Hence my comment at the beginning that I decided to come to this conversation curious but unplanned. And
with integrity.
Indeed, but it does feel slightly more anxiety provoking to do that. This is quite a new thing for me still. So that feels slightly anxiety provoking. But I'm aware that sometimes if I have notes in front of me, it may have come across more stilted, it may be a less genuine feeling conversation. We'll let the audience decide. But it's, again, a point of being a little bit brave about how you do something, I think.
No, absolutely. And I think it's just being human for me. It's that, you'll know yourself, we've all been there on the receiving end of healthcare at some point probably in our lives. You can kind of tell, can't you, when someone's genuinely there because they want to be there for you. It's hard to bottle that and it's hard to name what it is, but, you know, without drawing to any particular context, you know, or any particular type of treatment, I'm sure everyone at some level will recall a time or think of a scenario where they've perhaps not felt the person in front of them who's treating or supporting them has had their absolute best interests at heart. Hopefully that's very rare, people experience that. But if somebody's looking away at their notes or somebody's pre-prepared, as you rightly put it, they're not in that space between the two people. You've got to be able to sit with that slight discomfort of just not knowing. And, you know, and some of that comes from background, some of it comes from just some experience for some people, but I do think a lot of it comes from the environment people are working in and the culture in the team of whether they feel safe to just be present with their client. And, you know, often it's really liberating, but people feel it on the receiving end, don't they? Like if you've got a professional that's genuinely curious about what you're going through and they want to help you, you feel it in the room, you connect with it, you sense it, don't you, you know? And that's that intangible bit of, they obviously must be psychologically safe enough to just be in this space with me. And it's a good feeling, and it tends to lead to good outcomes, unsurprisingly, as well.
I think you're putting me in mind of two sort of experiences in my career. One at the beginning of it, when as a newly qualified physio, I just craved having tick lists and, you know, some kind of assessment form that I could take. And it was because I was worried I was going to forget. Because it wasn't practiced enough. And we were always discouraged from doing it as students. And then I think we all did it as soon as we were qualified. But that's more about your own feeling and your own concern about forgetting things. And actually, when you're working with long-term conditions, it's rare that you haven't got the second opportunity, the fourth, the fifth, the ongoing assessment. So actually, you don't need to. And I remember getting more comfortable with that when I then had students and being able to say to them, it's fine, you've already seen lots of things as the person's come in the room, that's what's frightening you. You don't have to capture them in one go. Contrasted with the scenario that I then found myself in a few years later of doing expert work, where you do go and you're trying to do one visit, and you're trying to understand everything about a complex long-term neurological condition, in my case. And with those kind of cases, and indeed I think with a lot of long-term conditions, there's oodles of paperwork. There's lots and lots of records as the years have gone on for somebody who's had a condition for a long time. And my view on that is it's very easy to go into the room with an idea already of what the person is, what the problems are. So not only prepared for your own assessment or meeting or whatever it might be, but actually with an awful lot of assumptions based on years and years of other people making their predictions or assumptions or whatever about you. And it was always better to not read very much at all. Name diagnosis, just so I've got a bit of an idea maybe how long ago the injury was. And over time realising, and I'm only reflecting on that now, thinking I was doing what you're talking about then. And it was better. I think the information you then get is more real.
Absolutely. And I think you make a good point there. You know, context matters, doesn't it? If you're going in a single appointment to, you know, ascertain some really important information to inform your diagnosis, your opinion as an expert, or, you know, a particular question that needs to be answered, of course you're going to have some set questions in your head. You'd be foolish not to. But I do agree with what you're saying. You know, if you over prepare, I always think of it, you know, I'm quite a visual person. I always think of it visually, as in the more you prepare, you bring those files in the room and you put them in front of the client and you. Like, the more files I read, I'm putting them in front of me and the client. There's like a wall in front of us because they can feel it. Yeah, like a barrier. Whereas the more I'm able to sit with the bare bones of what is the need of the individual from what I've read in the background, the salient information to make sure I can be sensitive to how I approach that appointment, that's important. And, you know, any risk issues that I need to be mindful of so I can support them. Once I've done that, the rest I don't read, like you, and I'm really open with that because I find it taints my openness and my willingness to sit in the grey with the individual. And I think, exactly as you say, yeah, it can feel uncomfortable, but then afterwards I usually find that I get more from it. And I just think at a really human level, if you ask yourself, when you're in a room with someone that you're going to see, are you bothered what they've got on the clipboard in front of you? Rarely the answer is yes. What you're mostly bothered about is whether they look you in the eyes, whether they genuinely seem to respond in their body language, their posture, their kind of connection with you when you seem to be hurting or struggling with something. That's what we look for: validation, connection. We don't really care how much they've read about us. You know, as long as they know a bit about us and they're with us in the room, that's normally the important stuff, isn't it? But, you know, we're all guilty of sometimes feeling anxious and needing to over prepare to settle that. But it's just recognizing and being mindful that sometimes comes at a cost to the relationship sometimes.
Yeah, and I think probably it's true to say not all of the time, but quite a lot of the time, again, with neurological long-term conditions, it may be that if you're becoming newly involved, it's because there are some problems, some issues, something that needs sorting. Otherwise, I guess we wouldn't be there. And it strikes me that more often than not, if you go into prepared with an idea of what that's about, you might miss the thing, because there are often issues that are rumbled on for quite a long time, and you're looking for a fresh perspective.
Yeah.
A way to find that maybe just little key that's going to unlock things. Not that there's always an answer and a key that's going to unlock things, but if there is one, it probably doesn't lie in what's already been done if lots of stuff has been done. So you've more chance if you go in very open to it all. But again, you've got to feel safe to do so. So we come circle back around to that safety again.
Yeah, and safety for the client. You know, if you think about exactly that example you've said there, if there's an issue in the team, or there's an issue in the dynamic of the treatment for that individual that's getting stuck, or you've reached impasse at some level that needs a new approach, if you're coming in as a clinician or as a treating therapist, if you're trying to get to that, the individual's probably more likely to tell you, the client's more likely to allude to it if they feel safe with you. They're not likely to tell you if it's a thing that they feel uncomfortable with or is very personal, if they've not formed a bond with you. I mean, why would they? You've got to show that you've got a vested interest in them. And, you know, that's where it's really interesting, because when we, you know, if you think about bringing in someone new to try and help or trying to make a good outcome, within the psychotherapy literature, there is absolutely loads of research that's been done since like the late 90s, early 90s even, that looked at, well, what is the biggest conduit to change? What's the significant factor? Is it whether it's this model or that model, CBT or psychotherapy? And actually, the thing that comes out every time is that the therapeutic relationship is usually the most significant factor, the therapeutic alliance that is the vehicle for change when you control for all the other variables, which isn't surprising, really. But
no, I guess it isn't, but everyone's always searching for measurable things, and the thing about that therapeutic relationship, the safety we've been talking about, you said it gives you the feels. You know when you're in it and it's good, when you're in it and it's not good, whether you are the patient on the receiving end or you're part of a team. But actually capturing the essence of that is quite difficult to articulate, which is why a long conversation around it is very interesting. So it can feel elusive, I think, is what I'm saying.
Yeah, and I think you're right. And I think in some respects, I mean, many years ago, I remember when I was doing my doctorate training, we went through a big period of trying to capture as an outcome measure whether we had a good therapeutic relationship. So I can remember as a doctorate student, and there's still some degree of importance that we could place on this. After certain sessions, saying, look, let's have a look at how this therapeutic relationship is working, and sort of trying to use subjective measures on scales of how close do we feel, are we making good progress, you feel comfortable with me. But the moment you start to objectify the feels in the relationship, it's really hard, isn't it? Because it kind of makes it a bit awkward and a bit weird and a bit like, oh, and you wonder if you've then got a response bias and all of that stuff around validity and whatnot. But I always think, the longer I've worked in mental health and neuro rehab, I've learned to realize that I don't really think I need to capture that as an outcome, because if I have it, the clinical outcomes prevail anyway. It's like if I have a good therapeutic relationship, I don't need to try and capture that. What I need to then make sure I'm doing is putting the right parameters and framework to capture the clinical outcomes that will come from having that good therapeutic alliance with the individual.
It strikes me that it's a bit like a bubble, that it's a bit ephemeral, that if you actually tried to hold on to it, it might just burst. And
yeah, it's a good description.
It might ruin it a little bit.
Yeah, no, I think that's a really nice way of picturing it, actually, that it does have to be handled very carefully, and it has to be sort of approached sensitively, as it's a sensitive subject, isn't it? And a lot of the research early doors about this, and I'm wholeheartedly biased around my preference. I like a lot of the work around Carl Rogers, in terms of person-centered therapy. And what is it? Well, it's about empathy. It's about, genuine listening. You can't be heavy-handed with that, because inherently it goes against being empathic and sensitive. You've got to connect with the person in the room and be delicate with that, and be respectful of that. You can't rush it. You can't rush to a let's fix this, because that's not listening. You've got to sit with the distress, haven't you? That bubble you talk about, you've got to kind of let it just grow, and you've got to sort of nurture it. But if you push it or if you force it, it pops, because then it just doesn't feel respectful. It doesn't feel empathic. It doesn't feel considered for what it is. Building a therapeutic relationship often, I think, requires that sensitive listening, empathy, connecting, and that is a very difficult thing to do, and it's a very sensitive process, isn't it?
It is, but it's probably fundamental across all of health and social care, I think. I mean, speaking as somebody who started professional life as a physio, I quickly realised that if you didn't do those things, then the physical hands-on skills were worth nothing, because maybe you'd be on the doorstep because the person had gone out and they certainly weren't answering the door. So you might as well not have the skills in the first place. So
absolutely.
It's very fundamental, yet very hard to codify and articulate in the ways we often want to.
Yeah, absolutely. And I think you're absolutely right. I think it takes time. And that's something that in modern healthcare is precious, particularly at the moment, as we know.
Yes,
it's very, very difficult. I've talked about it with other people regularly that the importance of slowing down at the minute is very, very, very high on my agenda, because if we speed up too quickly and try and solve problems in a reactionary way, whether it's with a client, whether it's in a service, whether it's in a system of healthcare, if we just react to it and we try and quickly fix it, we often don't take the time to listen sensitively and really understand it, which is exactly the thing we're talking about with a therapeutic relationship. You've got to form a relationship with that individual, that team, to really understand the needs. But it's hard to do, and it sometimes involves going against our instinct, because we might think we have the answer. I mean, you and I have been there. I'm there all the time. I'll think, I've got a great idea. I'm desperate to sort of share it. I have to like sit on my hands and sort of like think, no, don't, because I might be wrong. But experience tells you, doesn't it, that when you tolerate that, it tends to lead to a better relationship, which then takes you to where it needs to be, which might be your idea, but it might be something else.
But I think, given that we're recording this at the time of COVID-19 and just as we're easing from the lockdown, the idea of slowing down in this strange world we suddenly found ourselves in, where the pace of thinking and trying to come up with solutions is being very pushed, the idea of slowing down feels very counterintuitive. So those will be interesting conversations, I should think.
Absolutely, and I think now more than any other time that I've worked in healthcare with both hats on, I think it's been so pivotal to have psychological safety in teams, because this is not something as a context that we've got a script for. There is no script for this. That's why we all feel so out of control and overwhelmed at times with it, which is normal. But when there's no script for something and we don't know how to respond to it, if we react rather than slowing down, being curious, being unknowing, asking questions, feeling safe to say, do you know what, I just don't know what to do in this situation. What do you think we should do? If you can't do that, there's a risk, I think, or I certainly feel quite sensitive to that, there's a risk of reacting, not responding. And if we react too quickly without slowing down, feeling safe to ask questions, admitting we might have got it wrong, then actually sometimes the consequences can be quite severe. For the individual and for those that are involved in providing the healthcare. So I think now more than ever, psychological safety in teams, that considered, slowed approach to relationships, to really understand what's needed, is vitally important.
Well, I'm thinking that this is a part of the conversation that it would be very wonderful if people well beyond the usual NR Times audience here, because I suspect that has huge relevance across the board. Graeme, thank you so much for agreeing to succumb to my curious case management approach.
That's been wonderful. Thank you for having me. Thank you for having me along.
I feel like I should make a joke about the elephant in the Zoom. We mention the elephant in the room so often, but probably he's in the Zoom these days.
He is in the Zoom.
And to make reference to the fact that you did suggest we should embrace the people who are divulging that they feel they may have made a mistake. I'm assuming you mean at a social distance.
At a social distance, absolutely.
Thank you so much.
Thank you, Vicky.